session that we're going to be having in this very room. Sorry for the late start. There are some speakers of ours that we're still trying to locate, but the technical support team is going to continue with that process. So, of your time and your punctuality, we feel is just we can get the conversation of today. As I indicated, my name is Atsepo or Nikki, either one is good. And I work for the Global Equality Caucus as the Regional Manager for Africa. We have about 5 chapters that each have a regional manager on it. I head the Africa chapter, there's in Latin America, there's in Asia Pacific.
Always tell
America,
every session.
And,
You need to log out from the
and our work
Weirdly.
actually is to facilitate and administer to a network of legislators that are working with legislative champions or legislative leaders, as well as other influencers of laws and policy. But today is not about that work. It's very much related to that work in terms of the essence us to this very session that's looking at enhancing community approaches to uphold the rights of marginalized communities. And as you know, we're still running under the Icasa theme that reads Africa in Action, catalyzing integrated sustainable responses to end AIDS, TB, and malaria. And I'm joined here next to me by somebody who is an absolute formidable force, particularly within the region and even globally with the work that he does. And the session ideally is centered on that. Where do we place community voices within our HIV response, continentally and even globally? It also is looking at ways in which we can eliminate barriers and center those community voices in our very response in and of itself. Because I dare say that communities, we are the people with the lived reality, with the lived PhDs that should really be central to the way in which we do our HIV programming, tailoring our services, our messaging, our branding, and overall program and the overall continental response itself. And without further ado, I'd like to introduce to you Richard Moko, who is the Senior Programmer of Regional Implementation Advocacy at AVEC, who is responsible for campus program, implementing and coordinating key population work as part of the policy advocacy team at AVEC. His work centers on building the capacities of civil societies in Africa to engage effectively with PEPFAR, with Global Fund, and with the governments to strengthen the HIV response within the rights perspective. And prior to joining AVEC, Moko worked for the National Council of People Living with HIV, NACOPA, in Tanzania as a program manager and as a campus consultant for AVEC for 3 years, of which he also worked as a lecturer, consultant in a number of NGOs in Kenya, wider Sudan, Somalia, Italy, and a few other African and European countries. His work has mainly been in advocacy and organizational development. Thank you so much, Richard, for making this very time. It's incredible. I did a bit of research as I was preparing for this panel, and the anticipation I bring with me into this panel is one way I'm expecting markets of gold. You know for sure that our global HIV report itself via UNAIDS continually is speaking and recommending how we need to center community voices, how there has to be better partnership with civil society organizations and civil leaders. And as such is why we're looking forward to just hearing from you and what you have for us today. You're welcome. Please take to the podium. A round of applause, please.
Okay, thank you very much. I only have one slide. I don't know.
You didn't give us slide.
Okay, I I really thank the Icasa Secretariat and
He didn't give us
everyone,
slides.
who is here, uh, chair,
Pardon?
my panelists,
We
wherever
even
you
didn't
are,
know
my panelists,
100% until we saw him
for
sitting
this,
on
and
the podium.
I will
So
just
he didn't
start.
come to us to give us any
Um,
slides.
I thank the CASA Secretariat to speak on enhancing community approaches to uphold the rights of marginalized communities. I have chosen the name of my presentation this afternoon to be From Rhetoric to Reality, Resourcing Rights in the Accra, because Accra sets the future. We gather here in Accra. Our city is synonymous with the Accra reset. A whole man of Africa and sovereignty as we speak of Africa in action. We must confront a hard truth. You cannot build a high-performing health system on a foundation of exclusion. For decades, long before the arrival of major funding, and really we must thank especially the funders who have joined us in this struggle for all this time, the Global Fund, and all the international solidarity.
That's why I said we need cable.
It was our government,
Or it's
the
connected.
faith-based organizations, and communities who held the line. They were the first to offer dignified care to the marginalized, even in the most challenging times. Today, we must honor that history, not just with praise, but by ensuring our modern health in architecture does not dismantle the very safety nets these groups build. We are in a paradox. Science has outpaced our laws. Science is really going too fast. We have now long-acting injectable PrEP, the dapivirine ring, and a pipeline of tools that could end HIV. But science does not deliver itself. A vial of injectable PrEP or lenacapavir is useless to the young person who is too terrified of arrest and therefore cannot walk into the clinic. A prevention tool is wasted if a sex worker knows her presence will be met with judgment and not with care. So structural violence is an equal opportunity barrier. It affects us all. Yet specific groups bear the heaviest burden of this particular barrier. Let's basically start by highlighting them. First, we have the people who live with HIV. When we celebrate on one hand U equals U in conferences, but allow workplace discrimination, and stigma in our places of worship to persist, we force them into silence. We demand adherence to medication while ignoring poverty and isolation that makes adherence impossible. Secondly, key populations. When we design clinics that ignore the realities of MSM, transgender people, WID, sex workers, we actively push them away from the services that are intended for them. Let's go to vulnerable children. When we fail to protect the orphan or the adolescent girl from predation, we are not just failing a demographic, we are betraying our own future. People on the streets, when we enforce vagrancy laws that harass people on the streets, confiscating their property and driving them into hiding, we create a public health disaster. This population face peak exposure to HIV, violence, and disease, and other diseases. Yet they are the least welcomed in our health facilities. Let's talk about the disabled and the elderly. Where we build clinics without ramps, ignore the NCDs, or maybe products that are blind people friendly, or and of course we ignore also NCDs of our elders. We violate their fundamental rights to health. So how do we move from rhetoric of rights to the reality of implementation? First, we must bridge law and clinic with data. For too long, violations against these groups have been dismissed as anecdotes. We must now strengthen the use of CLM, that is community-led monitoring, as it transforms complaints into evidence. Imagine a system where the community is the auditor. They verify if KPs were treated with dignity, or if harm reduction services were available without police harassment. When we present government with data proving that exclusion directly crashes viral suppression and TB cure rates, the debate shifts from judgment to stewardship. CLM must integrate systems. And on this, I really would like to commend the government of Tanzania because they basically were able to integrate CLM into the national multi-sectoral framework, I think framework from national framework 4. Secondly, we must redefine sustainability as countries draft their sustainability framework and roadmaps for domestic resource mobilization. A danger lacks. We focus too much on sustaining the commodities, the pills and labs, and forget to sustain the enablers. If a national strategic plan or a universal healthcare strategy fails to budget for legal literacy, harm reduction, or stigma reduction, or enablers for the PWDs because it's viewed as a donor priority, it will fail. We cannot sustain the pills if we do not sustain the people. This is urgent as the global health architecture shifts through G2G, that is government to government agreements. The Global Fund's grant cycle 8 and the new PPR instruments, we must be vigilant. If a vulnerable child, PWD, street and homeless person, elderly and key population are not represented at the table during these negotiations, it's a fact that their specific needs will be the first one to be cut. We need explicit language in these treaties mandating community oversight. Yes, even in the G2G agreements. It's sad, we have basically seen pictures of the government, especially from Kenya, the agreements were signed, but communities do not know exactly what was basically in those particular agreements. So finally, we need social contracting. We cannot build a health system on the backs of unpaid volunteers. The community health workers, the FBOs, the community-led organizations providing critical psychosocial support, legal defense, and reduction are professionals. They deserve professional recognition. Do we agree about that? Government must develop a mechanism to pay them. Social contracting is a way of state admitting we cannot reach this group without you, so we will contract you to do it. After all, the work of the community actors is an extension of the work of the state. We must weave this workforce into national budgets, transforming marginalized communities from beneficiaries begging for help into partners contracted to deliver results. Conclusion, in concluding about African action, it demands we stop viewing the community as passive group to be reached, but starting viewing them as experts who must be resourced. And they are the taxpayers. Let us leave Accra with a commitment. Don't just speak about rights, measure them, fund them, institutionalize them. That is how we honor our history. You know, the history you talked about from the FBO community interventions in the beginning. And that's how we end these epidemics. We will not end epidemics without the community. Thank you.
Thank you so much for that, Richard. I have been taking quite a lot of notes, pardon me, because I definitely felt that there was quite a lot that you shared with us that was absolutely great. Gold nugget wisdom. I definitely love you as you were speaking about prevention tools being lost when many a times we request for that services that should be provided for are continuously denied, exclusionary and discriminatory, and they push those that
Okay, you've come to us, but is that how can you justify that? So we need as communities to continue doing what we do best, to document our own experiences and present it as evidence to the world. The age of consent. And
It's working now.
during that particular time, young people came and presented their stories. And it is those particular stories of those children that made the parliamentarians to adopt the particular policy. So, you as communities realize that your pieces of evidence that can really strongly inform the policymakers. But policymakers make a deliberate effort to reach out to the communities.
thank you so much for that, Richard. And just one more question, which might not necessarily be something that is just easy to respond to, but do you think that our 95 global targets are reached given the current context that we're in? And what would you say will get us there? Because I was looking just a couple of days ago that Lesotho has just become one of the 7 countries globally who have actually exceeded the 95 targets, where they have reached 97. And the question remains, what do we learn from those very countries that have
in the recent replenishment drive, we fell short of 7 million. That in itself is really, if at all, let's say,
When I
if
thought you
you
can hear.
remember exactly
So wait,
the
wait, wait,
dates,
wait.
then you know exactly.
Leaders need to think critically around prioritizing health, prioritizing HIV, which unfortunately has become quite deprioritized, and we need to return it onto the table of our leadership. As we now continue, friends, with this very conversation, I'd like to invite some questions and interventions or even comments from the floor itself. If you have something that you want to direct this way that Richard or myself can be able to take on, please just raise a hand. I don't know if we have, yes, somebody's coming to you with a roving mic. I see a hand over here. And then I recognize the hand on the other side as well. And we will then give Richard the opportunity to respond. Please go ahead.
Thank you so much, and thank you, Richard, for the beautiful presentation. And I just want to specifically speak to your call to action on communities documenting their experiences. I think as time goes on, we are trying to devalue the meaning of lived experiences. So the fact that I'm privileged that I sit on different decision making platforms. The fact that I come and share my lived experience, and I am open living with HIV and come and tell you the realities of living with HIV, the challenges that I face accessing services. That should be enough for the government or for the partners or stakeholders that are concerned to start investigating. It should be an entry point, the fact that a community member came out to speak about their lived experience. But if I come and I share my experience and then you tell me to go back home, document, you're now calling for numbers. Communities, we do not understand numbers. We understand the realities that we are facing. So this is my call to action as well, and you could also speak to that let our lived experiences be a starting or an entry point for investigation, because you say that we have to bridge law and data. So this is where we need to start. If we come out, share experiences, don't disregard us, don't dismiss our experiences because it's not documented in numbers. That alone is evidence. Thank you.
Thank you so much for that powerful intervention. Definitely. I had recognized the hand on this side, please, before giving Richard the opportunity to respond.
Thank you very much. My name is Richard from South Africa. Thank you,
Oh,
Richard.
beautiful. Rich to rich.
Yes, thank you very much. Thank you for your presentation. Indeed, the community-led monitoring is very good because that is where we find, we collect the data to find the challenges that that community are facing. However, we need to work together with the government. We need that collaboration strategy on how we can work together in order to close that gap on healthcare system, because the government is community and the community is government. So we all need each other to how to close the gap on that on those that we have mentioned, Richard. That's what I'm proposing, that collaboration. That now is a time to collaborate in order to closing the gap. It's not a time to say why you didn't do this, why you're not doing this. We talk about collaboration now, that we are civil society, you are the government. If we do this in one, we can reach our goal and we can close that gap. Thank you.
Thank you so much. So, Rich, coming from another Rich, we are definitely noting that CLM is something that's very resonant across board. Well, I think the intervention that also came in earlier, the call to action that is demanding of us to really harness the power that we carry with our lived narrative enough to use them to influence and change and shift hearts and minds. What's your take and your response to these interventions?
Thank you for that particular interventions. Indeed, our our lived experience is enough evidence. Just like the example I gave of the young, of the adolescents who provided very deep stories that touched the parliamentarians in Tanzania. And of course, I think the story of the age of consent in so many other countries, it was not as like what was done in Tanzania through the of NACOA and organizations. Our own CLM data. For example, there are various platforms. We have had the iMonitor, of course, I'll speak about them later, or we have also had ComCare. But unfortunate, with the shrinking of donor funding, we lost some of this particular data. So we, as non-proprietary data platform understanding that requires of this particular data. Very important.